everyone, welcome back, where we break down NAPLEX style questions, get our brains working and make pharmacy fun. I'm your host, and today we're tackling some challenging NAPLEX questions to get you prepped and ready. Grab your coffee, settle in, and let's dive into these tricky cases. By the end of this episode, you will be mastering these questions like a pro. Let's get started. A 60-year-old male with type 2 diabetes, chronic kidney disease stage 3, and hypertension has a blood pressure of 160 over 95 millimeters of mercury despite being on lisinopril. His potassium is 5.3 milliequivalents per liter, and his eGFR is 40 milliliters per minute. What's the next best step in managing his hypertension? All right, let's break this one down. The patient has resistant hypertension, diabetes, and CKD, so we need to be careful with anything that could further affect potassium or kidney function. A. Increase lisinopril dose. Nope. Increasing the lisinopril could push his potassium even higher. And with a potassium of 5.3, we're already flirting with hyperkalemia. Not a good idea here. B. Add hydrochlorothiazide. Thiazide diuretics can lower blood pressure, but they lose their effectiveness when kidney function is impaired, like this guy's eGFR of 40. So, not the best option. C. Start a calcium channel blocker. Yes, calcium channel blockers like amlodipine are a great choice in CKD patients to help control blood pressure without affecting potassium. This is the winning answer here. D. Start spironolactone. While spironolactone is great for resistant hypertension, it also increases potassium. Given this patient's elevated potassium, adding spironolactone could lead to dangerous hyperkalemia. Hard pass. Takeaway message is when treating hypertension in CKD, watch that potassium. ACE inhibitors or ARBs are great first-line options, but if they are not enough and potassium is creeping up, calcium channel blockers are your friend. Next up, we have a 50-year-old female with metastatic breast cancer who is already taking extended release morphine 60 milligrams twice daily, but is still having breakthrough pain. What's the best option for managing her breakthrough pain? So, we've got a cancer patient with breakthrough pain. Let's break down these options. A. Add immediate release morphine. Ding ding. This is our go-to move for breakthrough pain. Immediate release morphine can help manage those peaks of pain between her regular doses of extended release morphine. B. Switch to transdermal fentanyl. Fentanyl patches are great for long-term pain control, but they take time to kick in and won't address the breakthrough pain she's experiencing right now. C. Add gabapentin for neuropathic pain. Gabapentin can be helpful if her pain is neuropathic, but we don't know that from the case. We're focusing on managing her breakthrough pain here, so not the best choice. D. Increase her extended release morphine dose. This might be tempting, but we want to focus on treating her breakthrough pain specifically. Upping the ER dose won't give her the immediate relief she needs. Takeaway message is, breakthrough pain in opioid-tolerant patients is best managed with short-acting opioids. Keep that immediate release morphine on hand for those spikes in pain. A good rule to remember is long-term control, short-term relief. All right, last one. We've got a 72-year-old male on warfarin for atrial fibrillation with an INR of 4.5, but no signs of bleeding. He's been stable on his current dose for months and denies any dietary changes. What's the best course of action? Okay, first, his INR is elevated, but he's not bleeding. So we don't need to panic or jump straight to aggressive interventions. Let's check these options. A. Continue current dose and recheck INR in 1 week. This could be risky. His INR is already pretty high, and if we leave it unchecked, it could climb even further. B. Hold warfarin for 1 to 2 days, then resume at a lower dose. Yes, holding warfarin for a couple of days will let his INR come down without putting him at too much risk for clotting, and then we can lower his dose to keep it in the therapeutic range. C. Administer vitamin K. Not necessary here. Vitamin K is for when the INR is really high or there's active bleeding. Since he's stable, we don't need to go this route. D. Stop warfarin permanently and switch to a DOAC. Not yet. This patient's been stable on warfarin, and we don't need to switch medications just because of one elevated INR. Takeaway message is managing warfarin is all about balance. If the INR is up but there's no bleeding, holding the dose for a couple of days is usually the best approach. And hey, don't forget that warfarin loves to play around with food, meds, and even stress. Always keep an eye on those Indian rupees. At this point, I want to give you a few Naplex tips. Chronic conditions like hypertension, diabetes, and anticoagulation management are huge Naplex staples. Get super familiar with the first-line treatments and know how to tweak them based on lab results like potassium, EGFR, and INR. Pain management is another favorite. Remember, when patients are already on long-acting opioids, use short-acting options for breakthrough pain. For anticoagulation, especially warfarin, INR management is key. Understand when to hold doses, adjust, and when to administer vitamin K based on bleeding risk. Oh, and let's not forget the mnemonics. For warfarin management, 4 to 10, hold the pen, 10 plus, give the K, and pray. Did you hear clearly? 4 to 10, hold the pen, 10 plus, give the K, and pray. Meaning for Indian rupee between 4 to 10, hold warfarin. For Indian rupees above 10, give vitamin K. And that's a wrap for today's episode, folks. We tackled some tough Naplex questions and hopefully made the process a little less intimidating and maybe even a bit fun. Remember, it's all about learning the logic behind these questions, so you'll be ready for whatever the exam throws at you. If you enjoyed this session, don't forget to subscribe and share it with your study buddies. Stay motivated, stay curious, and keep those brain cells buzzing. Until next time, happy studying and good luck on your journey to becoming a licensed pharmacist. Take care, everyone.